to maintain good fluid and electrolyte balance. The losses do come from possibly having the nasogastric tube and having suction. They could be vomiting, so they're losing electrolytes and fluids that way. There could be a third spacing, so maybe they have ascites buildup. And we said the body gets used to it, but it really is not utilized for much. So it's not helpful to maintain their electrolyte volume. It's not useful to maintain their cardiovascular volume, etc. So they need IV fluids. We might use something like lactated ringers. We do have volume expanders like colloids, like dextran or albumin, that can help with our intravascular volumes. C, we can monitor for ascites and hemorrhage. We can do that by measuring abdominal girth. One of the big questions sometimes that will come on abdominal girth is the first person who takes the measurement should mark on the belly where to put your measurement tape so that everybody's measuring at the same spot. Okay, so if Perry does it, Perry's going to make a mark on the abdomen so that when Amber comes in the next shift and she's measuring with the measuring tape, it's at the same spot. And when Nikki comes in, it's measuring at the same spot. So that's probably one of the biggest things they ask about with abdominal measurement is everybody measuring at the same spot. Then letter D, careful monitoring of fluid volume, intake and output. They might be on hourly outputs. If they have a severe case, they may be in the intensive care unit and have some type of central venous pressuring, measuring the vomitus, how much diarrhea do they have, how much is coming out of their nasogastric tube. And of course, if they're having excessive diaphoresis with fevers and those kind of things, that can alter our fluid levels also. So we want to watch that. So what are some things that we can do to manage the patient? Well, for a surgical management, we can actually do a sphincterotomy. And the sphincterotomy is done with an endoscopic transduodenal procedure where we put the scope in and they actually go in and make that outlet larger. They can do it for abscesses. They can go in and remove large cysts. They can do it for severe peritonitis, and they can do it for any type of associated biliary tract disease. So a sphincterotomy, if you think of otomy, we're creating a hole. So the best analogy I can think of is folks that go in and have sinus. They have chronic sinus issues, and they'll go in and clean the sinuses out, actually make those sinus cavities, those holes a little larger, so that all of that stuff drains easier for the patient. This is essentially the same thing. They go in and they make that hole, that outlet, just a little bit larger. And so the premise is then that things cannot get built up behind it. And hopefully we would not have pancreatic issues again. Complications. There are several. The first is an abscess that your notes talk about. They can form clear up to 6 weeks or more after that they have their onset of their pancreatitis. They can get an epigastric mass that is very tender to them. They can have an elevated WBC and an elevated temp. And what we would do would be antibiotic therapy for their abscess. We would do CT scans to see if it's resolving itself, or we could go in and have a drainage done of their abscess.
I have a question. Is my understanding correct then that ulcers can cause the pancreatitis, or ulcers are a result?
So just an abscess mainly there, Perry, not necessarily an ulcer. So an abscess is going to be a pocket of infection that's occurring, and an ulcer is going to be some type of erosion. Okay, so two separate things here. The abscess is going to be a buildup of some type of infected material, and then an ulcer would be more like in the lining of a tissue where it erodes through, and you might have a bleeding ulcer or pain or something that's caused from it. So in this case, it's going to be two different things. Does that make sense to you?
Yes, that is. Thank you.
Okay, all right, good. The second problem that we could have would be a pseudocyst, and this is again something that can develop down the road. The encapsulated fluid increases, and so your 6 is going to be an arrow up there. It can develop in the pancreas or the abdominal cavity. It can impinge on other structures, and it can rupture, and if that material ruptures, it actually could cause a peritonitis for us. We'll monitor it. Sometimes they wall themselves off. They'll just actually reabsorb gradually. If they don't, they may have to go in via endoscopy or surgically actually remove that. Okay, again, these are complications that will occur on our highly moderate or our severe patients, not our mild cases of pancreatitis that are there for several days within the hospital just with pain and nausea. Okay, these are people that have full-blown long-term pancreatitis for us. Our third one is ascites. And this is probably a third world country person because we're dividing the patients with a large with a large sheet, and we wouldn't have that in a developed country, hopefully like the United States. So again, third world. But can you see how much fluid can build up within the abdomen? That's huge. Okay? So it looks like in this particular patient that they actually here have put in probably a drainage tube that they can periodically release fluid from. And we have those in patients. You'll see them in your hospitals. People that have chronic health issues, maybe tumors or something that's producing acidic fluid, they'll put drains in them, not only in their chest, but in their abdomen, so that families can drain them at home. They don't have to be hospitalized to have a paracentesis or a thoracentesis all the time. Now, can you imagine this belly and how well this patient is breathing? I mean, that has to be pushing on his or her diaphragm and causing quite a bit of shortness of breath. So I would say that this tube is in here for palliative treatment and for comfort management. And then you can see here, it has caused a periumbilical hernia for this patient. This is her belly, his or her belly button that's pushed out because the amount of fluid that's here. So this is an extreme case, but I just want to show you how much the abdomen can expand and actually hold fluid. So if you're having this much fluid, you can imagine the whole innards of your body is not functioning very well due to that. Your bowels wouldn't be working very well, you wouldn't be hungry, your lungs, you would be having difficulty breathing due to it. Just a lot of things that go hand in hand. All right, so what can we do with this? We would monitor their abdominal girth size. Actually, we could put in some type of drain. They could have a paracentesis to remove fluid, or we could go in surgically and hopefully see if we could remedy something that way, depending upon what was causing ascites. We talked about enzymes that can travel to the pleural cavity. So when it's in there, it can actually cause pleural effusions. So if you look at the picture here, the problem that we have in this case is that this lung is fully expanding. This lung is being impeded because we have a buildup of fluid. So it really is mimicking a pneumothorax. Only instead of air causing our problem here, it's fluid that doesn't allow for full lung expansion. All right, this is just a buildup from pancreatic enzymes leaking through that lymphatic channel into the lung cavity, okay, and it's allowing these fluids to build up. What would we do? Well, if it doesn't stop and we can't remedy the pancreatitis, We might have to do a thoracentesis or put in a chest tube to relieve this fluid so that the patient can breathe better. So it's really not a lung issue causing it, it is a pancreatic issue causing the pleural effusion. So if we tapped this fluid from our thoracentesis or our chest tube and we actually analyzed it, it would have pancreatic enzymes in it. Okay, and that would be telling us then to the physician or the pathology person that this is a pancreatic issue and it isn't from a tumor or anything in the lung causing the issue or congestive heart failure or anything like that. It actually is a pancreatic problem. All right. So those are some complications that can occur then with our pancreatitis. So we've got our patient better and they're going to be leaving. So it can be a long recovery. I say that because if we don't really know what caused it in the beginning, we didn't have gallstones, sometimes medications can cause pancreatitis. If it's an alcohol issue, we know that just telling somebody to stop drinking, if they have a true illness of alcoholism, is not going to stop. So that's what we mean by a long recovery. And our patients that have severe pancreatitis, it is going to be a long recovery because a lot has happened to them due to their pancreatitis. They need to understand their disease, what caused it. They need to avoid alcohol because alcohol causes increased stimulation and we don't want that to happen. They'll need to maintain their medications. Sometimes they get put on diabetic medications due to this. Sometimes they get put on pancreatic enzymes to help with digestion until their pancreas can completely heal. And we'll talk about those at the very end of the lecture. How do we give pancreatic enzymes? How do they take them properly? Instructions for that. Report any signs and symptoms of reoccurrence for them. Monitor glucose levels. We said sometimes complications can be that they develop diabetes. Could be short term. If their pancreatic gland or organ heals well enough, that may slowly dissipate. It may not. And then diet, we said diet that is low in fat and low in stimulants and low in protein initially will be easier for them to digest. Okay. All right, so I'm going to let you take a 10-minute break, come back at about 2 till 11, and then we'll talk